Why should endpoints other than that non-inducibility be considered in substrate ablation for ventricular tachycardia?
Well, non-inducibility is a good endpoint, and it has been the gold standard. However, some patients do not have inducible ventricular tachycardia. In addition, the reproducibility of the response to program stimulation or non-inducibility may vary somewhat. So it's good to have additional endpoints that you couple with non-inducibility to reliably predict a good clinical outcome.
For non-ischemic cardiomyopathy patients, which post-ablation tests do you think are fundamental to minimize VT recurrence?
I think that non-inducibility is a good endpoint to use. That's step one. In addition, we should have some measurable effect from the ablation that we've performed. That might be elimination of late potentials, what we refer to as a core isolation of an area of myocardium that's responsible for the genesis of ventricular tachycardia, and that by surrounding it and then demonstrating non-excitability in the center, we indicate that that is an area of core isolation, and that may also be a good secondary endpoint.
Repeating post-ablation tests may prolong procedural time. Will this increase the procedural risk, and how can it be avoided?
Well, there's no doubt we want to minimize the risk to patients and must individualize therapy. So there are some patients who are too sick to undergo stimulation after an ablation procedure. However, in most cases, with the appropriate attention to the status of the patient and hemodynamic support if necessary, one can do program stimulation at the end of the study, and one can even repeat the stimulation safely. In many patients, if we decide that it's unsafe to do stimulation at the end of the study because of hemodynamic instability, it is advisable to actually bring the patient back a day or two after the procedure once stability has been documented, so that we can perform the stimulation through their ICD device and demonstrate that they no longer have ventricular tachycardia. Recently, we've demonstrated that if they have persistent inducible clinical ventricular tachycardia, this is associated with a poor outcome and may require early repeat ablation in order to improve outcome.
What is the advantage of absence of VT recurrence?
Well, it appears at the end of a study, if we can make the patient non-inducible, they do not have high likelihood of VT recurrence, and the absence of VT recurrence long-term has been associated with improvement in survival. So patients who don't have VT and recurrent ventricular tachycardia will tend to have an improvement in their survival.